Assalamu alaikum, welcome to Minute Maths. Now we are going to study about arrhythmias. Now we will discuss the common arrhythmias that we come across in our ERs or sometimes in the ICUs and the CCUs. Now at the end I will tell what would be the approach of any arrhythmia, but now we just go through one by one. The first one, the commonest, is atrial fibrillation. Now, as the name says, the atria is fibrillating. So it means that the rhythm would be irregular, and in these patients and in any arrhythmia, mostly how the patient comes to us is usually the palpitations, the dizziness, or the chest discomfort. These are the usually the presentation of all the patients that have arrhythmias. Now, what are the common causes that can lead to this condition? Is the heart conditions. Now, almost we start with the hypertension. This is also a cause of atrial fibrillation, the commonest one. Ischemic heart disease, cardiac failure. As the ischemic heart disease, the ischemic component can lead to re-entry circuit, can make an re-entry circuit in the atrial fibrillation. Now, these are the heart conditions. What else? What other problems can lead to this? Sometimes chest infection like pneumonia, it can lead to this. And then the respiratory problems, apart from others, is a pulmonary embolism. And then any endocrinological problem is thyrotoxicosis. Now I will give you the general review that if a patient comes to you with atrial fibrillation, how would we approach? Usually, as I said before, the patient usually come with palpitation, chest discomfort, dizziness. Now, if the patient comes with this, the first thing what we do is to check the pulse. If the patient has atrial fibrillation, then the pulse is usually irregular. Then we check the blood pressure. Is the person maintaining the hemodynamic stability or not? If the person is having the blood pressure of less than 90/60, is hemodynamically unstable, then the treatment would be different. And if he or she is maintaining the blood pressure of greater than 90/60, then the treatment would be different. Then we check for the signs of what we are talking about. These things. Is the JVP raised? Is there any evidence of medial edema? Is there any evidence of displaced apex? For heart failure we're talking about. Is there any gallop rhythm associated with it? Is there any other added sound in heart failure? Functional murmurs of myocardial agitation. Is there any evidence of bilateral fine cracks for heart failure? Then on the back of the chest, any side of bronchial breathing. Why are we doing this? To find the cause of this. हमें पता चल गया कि this is atrial fibrillation by irregular pulse. We'll get to the ACT. Then to find the cause, is the patient hemodynamically stable? Then to find the cause, is there any associated heart failure as we have checked over here? Then we check for any palpable thyroid gland. And then the investigations. The first baseline is at an ECG. ECG में in the case of atrial fibrillation क्या चीज़ मिलती है? There is absent waves and irregular pulse rhythm. This is the presentation of atrial fibrillation on an ECG. What would we do next is to get an echocardiogram. Echo में हम लोग क्या देखेंगे? यही फाइंडिंग हमने देखनी होती है कि is there any evidence of hypokinetic segments? तो ये हम बात क्यों कर रहे हैं? Hypokinetic segments they signify any ischemia in the past. Then there is diastolic failure in the form of concentric hypertrophy. So diastolic failure. What else? If there is dilatation or if there is whole hypokinesia of the whole of the heart, dilatation, any evidence of cardiomyopathy. To find the cause. Remember, we are doing this to find the cause. Then the respiratory problems. We'll do chest X-ray for any new infiltrate, for pneumonia or any wedge-shaped opacity in the form of pulmonary embolism. And then, as we said कि endocrinological causes भी हो सकती हैं, we send the thyroid function tests. So this is the usual workup of a patient, any patient, which comes to you in the ER or in the OPD with atrial fibrillation. Now, how we segregate the patients in terms of severity. So, investigation aside, a patient come to you with palpitations, discomfort and then dizziness. सबसे पहले यही बात करते हैं. हमने देखा कि पेशेंट की पल्स जो है that is about 126 beats per minute. That is irregular. Next thing we're doing is हमने देखा कि blood pressure कितना. Suppose this is this less than 90/60. The patient is not hemodynamically stable. The patient, the most significant component in the case is dizziness. Then if the patient is unstable, then we have to go for the electric shock cardioversion, electrical cardioversion. So segregate the patient in terms of the patient is stable or not. Unstable. If the patient is unstable, as he has dizziness, hypotension, then we give DC cardioversion, electrical cardioversion. In about 50 to 100 joules. So there is a problem with the patient. We don't know for how long the patient has been in atrial fibrillation. And if the atria is fibrillating, there would be stasis. The stasis of the blood can lead to the clot formation. And if we suddenly cardiovert the patient, that clot can go upward or downward. In the upward in the form of stroke, and in the down in the form of intestinal ischemia, for instance. So what we do is we heparinize the patient, and then the electrical cardioversion. Period. There is some instances that if we don't have electric cardioversion available, then we can do the chemical cardioversion. we can use amiodarone, digoxin, for instance. But usually, remember, if the patient is unstable, go for the electrocardioversion. If the patient is stable and the patient is having a irregular rhythm, then what we do? We have different class of drugs like beta blockers. Now, here the confusion starts. When to give beta blockers and when to give other drugs. In the cases if the patient has structural heart disease, then we prefer to give them beta blockers. What sort of structural heart disease? That I have discussed before in the cases of ischemic heart disease. If the patient has hypertension, if the patient has heart failure, and if the patient doesn't have any structural heart disease, then we can give the class 1C drugs like flecainide, like propafenol. Then the class 3 that can also be used like amiodarone. But it has very serious side effects. This is the usual approach of a patient with atrial fibrillation. Now there are different confusion things in this. There are certain definitions that what is permanent atrial fibrillation, what is persistent, and what is paroxysmal atrial fibrillation. This thing has nothing to do with this clinical scenarios, but just for the sake of knowing what is paroxysmal, persistent, and permanent atrial fibrillation. Our definitions: the paroxysmal is the atrial fibrillation. The patient has bouts or episodes of this irregular rhythm that usually get normal by themselves in less than 7 days. The persistent, that for more than 7 days. Permanent, that even doesn't, the rhythm remains the same. We can control the rate, but the rhythm remains the same. There's another thing that we sometimes use, lone AF. I have discussed in the beginning the causes of atrial fibrillation. The lone atrial fibrillation is the type of atrial fibrillation in which there is no significant cause found. Now, we just discuss scenarios that how atrial fibrillation can present. Now we now first scenario is a 23-year-old female on carbimazole from last 1 year. She is non-compliant to medication. Now she presents to you with palpitations, chest discomfort. On examination, our pulse is, or heart rate is about 121 per minute, that is irregular. She is maintaining a blood pressure of 100 by 60 millimeter of mercury, and there is no significant abnormality on clinical examination apart from palpable thyroid. Now, how would we diagnose this patient? how we go for the workup, and how we treat the patient. Now look, diagnosis, we know that a patient, she has a cause, she has a risk factor of thyrotoxicosis, that she is taking carbimazole. She is not compliant to medication. She has a heart rate of 121, that is irregular. Now, a provisional diagnosis in this condition is atrial fibrillation. Now, how would we confirm the atrial fibrillation? Our diagnosis is first get an ECG. What would ECG show? The absent P waves. And it would have irregular rhythm. What else can we do in this case? We'll go for the echocardiography. For what? For any structural heart disease. Young patient of 26 years. What structural heart disease we are looking for? Any valvular lesion or cardiomyopathy. What else can we investigate for? Is thyroid function tests. So this is a workup. How will treat the patient? Now, as I have mentioned in the question, that the blood pressure, she is maintaining blood pressure and she is clinically stable. Apart from having palpitations, she doesn't have any other issue. So we don't need any cardioversion or shock. We just go for the pharmacological treatment. So the pharmacological treatment would be, as we have mentioned before, what are the drugs that can be used? Beta blockers are options, calcium channel blockers, the rate limiting. These are the options. And then, as I've said, the beta blockers are usually preferred in the cases of when the patient has some structural heart disease, but they can be used in these patients as well. Then we can use the class 1C drugs like flecainide or propafenone. Now, what would we do? The patient has thyrotoxicosis, and we advise the patient to continue with carbimazole. Now, if the patient comes to you and this atrial fibrillation doesn't resolve, what other treatment options we have? We have the treatment options of catheter ablation. You can go for the catheter ablation. This is how we treat atrial fibrillation according to the patient. Now, another scenario. Now, a 50-year-old male, hypertensive from the last 10 years. He is taking losartan and potassium for the same duration of time. Now he presents in the ER with dizziness, palpitations, and chest pain. Now, on examination, on the pulse is 121, that's irregular. The BP in this case is about 80/50. And there is no other significant abnormality on the chest. On the recording, there is no other abnormality. In this condition, and the question gives you a clue. When the ECG of the patient is done, that shows absent periods and an irregular rhythm. Now, how we perform the workup, additional, how we treat the patient. Now, in this case, the patient clearly has atrial fibrillation, and then the patient is unstable. How we treat? Before the workup, now the patient is unstable, we have to give him DC shock 50 to 10 joules, and as we said, we have to heparinize the patient first. We give patient heparin, then we give him a shock. Then, after giving the shock, when the patient has stabilized, the rhythm has come to the normal, the patient has regained the consciousness, then we can switch on the patient to other then the management protocol changes. That shows the rate limiting drugs like beta blockers or the calcium channel blockers. These are used to keep the rate in control, and then we work up for the causes. As I've said before, the echocardiography for any valvular incompetency, any incidence of hypokinesia, or diastolic dysfunction. Now, one additional thing, we put the patient on beta blockers or the calcium channel blockers, and other, as I said before, the flecainide can be used, metron can be used. This patient has atrial fibrillation, stasis, then stasis, so we know that there is a risk of getting a stroke, we're getting thromboembolism, so we have to prevent, we have to take measures to prevent this event. Then we have a score that which patients with atrial fibrillation should be given drugs and which should be observed only. So there is a score called CHADS 2 VAS score. So C for the congestive heart failure, H for the hypertension, A for the age greater than or equal to 75 years, D for diabetes mellitus, S for any stroke or the TIA in the past, B for any vascular disease like peripheral arterial disease, A again for age. Look, A comes twice. This age signifies the age from 65 to up to 74 years. And then this is the female gender. Now, whole this constitutes about 9 points. Now, when to give prophylaxis? This is the point. If the CHAD VAS score it is 0, then no prophylaxis should be given. I'm going to write it over here. If the score is 0, no drug is used. If the score is 1, then we add aspirin to the overall treatment that he or she is taking. And if the score is 2 or greater than 2, then we start the anticoagulants warfarin. Or now we have other drugs like rivaroxaban. Now the anticoagulants are used. We, in the cases of warfarin that is commonly used in this condition, we monitor the INR, the international normalization ratio, that is usually 1, and we keep it between 2 and 3. We adjust the dose according to this. So this is how there are two scenarios discussed, and how a patient with atrial fibrillation presents to you and how the treatment changes. And regarding the things like different definitions of the persistent, the permanent, and paroxysmal that I have also discussed, and then the lone AF. Now, there are small talk about other arrhythmias like supraventricular tachycardia, like atrial fibrillation, but that is regular, having the regular rhythm, or regular tachycardia. How we manage such a patient? With regular rhythm. No, just one thing about the point of why we call it supraventricular. It means that in this condition, in these arrhythmias, apart from having the same clinical presentation as I've said before, when you look at the ECG, the ventricles, the QRS complex, these are normal. So we mean by this is that the problem lies above the ventricle, where the AV node even. So we're talking about the SVTs. These are usually divided into two, or we can say that it is AV and RT, that is AV nodal tachycardia. So in AV nodal reinterval tachycardias, the patient usually present just like as I've said before in atrial fibrillation with palpitations, nausea, might be dizziness. Some patients only present with palpitations. Some patients with so the presentation ranges from palpitation, nausea to dizziness and dyspnea. And on examination, the pulses ranges from 120 to 40 beats per minute, and it is regular. Please mind this is regular tachycardia. Now the blood pressure. Again, it can range from less than 90 by 60 to a good handsome blood pressure. Now, how we treat such a patient? Now, in these conditions, the first investigation to be done is the ECG. Get a closer look at the heart. We see that there is regular tachycardia. With normal QRS complexes. Now, what else can we do? As I said before, we can go for the to look at the causes. We can check the echocardiography. Look for the causes. Then, and the causes are ischemic heart disease, as we can, as I have said before, structural heart diseases like ischemic heart disease, like cardiomyopathies, like the heart disease. Now, how we treat such patients? Again, we segregate it into two groups: the stable patients and the unstable patients. Now, the patient who was unstable, having dizziness, having dyspnea, and on examination the blood pressure of 90 by 60. These needs are TC shock. 100 to 200 joules right away. And who are stable but having only the palpitations, and having a blood pressure of greater than 90/60, these are giving the pharmacological treatment in the form of the first drug that we usually give is adenosine. And before that, yes, before giving, we can go for any maneuvers like Valsalva, maneuver can be performed. Then the oculocardiac reflex, in which we compress the eyeballs, that can lead to the enhancement of the parasympathetic activity of the heart. Then there are other methods like carotid massage. So these are the first line treatments. If these doesn't help in a patient, then we go for a pharmacological treatment like adenosine. We give 6 milligrams and we can repeat the dose. Or we can go for any calcium channel blocker in the IV form like verapamil. Or we can go for a beta blocker. Like metoprolol. So this is how patient come with this, and you come to know from the ECG that this is a regular tachycardia. If the patient is unstable, you have given a DC shock. If the patient is stable, you perform these maneuvers. If there is no response, then you can go for the pharmacological treatment. Now, you have reverted the supraventricular tachycardia. Now the patient is stable. Then what would be the treatment for home? Now the patient is stable. You have reverted that condition. Now, some conditions for the prophylaxis, we can use beta blockers or the calcium channel blockers, which are rate limiting, like verapamil or deltiazem. What are the other treatment options? The other treatment options in this condition is catheter ablation. Just remove that aberrant focus by ablating it. Now, our last arrhythmia is the ventricular tachycardia. So we have done with the supraventricular ones. Now go for the ventricular tachycardia. And another, just one thing about supraventricular tachycardia, there is a type of supraventricular tachycardia in which there is AV nodal repeated tachycardia, and there is a component called WPW syndrome. Now, just a few words. The patient usually come with the same complaints like the palpitations. The patient has chest discomfort. Patient might have dyspnea or nausea. Examination. The heart rate is greater than 120, but it is regular. He is maintaining a BP of 100/60. Now we look at the ECG, and there is regular tachycardia. But there is one thing that is different from the supraventricular or the AV nodal repeated tachycardia that we have discussed before. And this is, there is reduced PR interval. and there is slurring of the QRS complex, that is called a delta wave. Now this is a supraventricular tachycardia. Sometimes there is absence of this finding, but this usually comes. So in this case, what happens in WBW syndrome, there is apart from having an aberrant foci, that is something else, but there is another way, there is another pathway for pathway of circuit between them. This is connection between the atria and the ventricles, a new way, and that causes this reduced PR interval. And in this condition, in the patient who have WBW syndrome, the first line treatment is catheter ablation. And then for the prophylaxis, or we can give, until we have this facility available, we can send the patient on the beta blockers. So this is about supraventricular tachycardia. Now the last one is ventricular tachycardia. As the name suggests, the heart rate is more than 120, more than 100. But the origin of this arrhythmia is from the ventricle. And as all the arrhythmias present, the patient comes with the same complaints like palpitations, nausea, dyspnea, dizziness, in the context of having any heart condition before, like previous MI, having hypertension, or mostly in the context of having an ischemic event an hours or days before or in the past, mostly. Now a patient comes to you, any 50-60 years old, with these complaints, with a history of ischemic heart disease a year back or a month back, and on examination what you are looking for to look at the pulse. So on examination, I'm looking for the pulse that is greater than 120 per minute, that might be regular or irregular. So look at the blood pressure, check hemodynamic stability. So that would range from less than 90/60 to more than 90/60. So, and the ECG shows no association between P and the wave in the QRS complex, and the QRS complexes, these are white. Now here again, how we treat such a patient. If the patient is stable, what would be our approach? And the patient is unstable, what would be our approach? If the patient is unstable, like any arrhythmia, we have to go for the DC shock right away. 250 to 300 joules. If the patient is stable, then we have drugs, like we can give intravenous amiodarone, or we can go for terminus lidocaine. Now, when the patient has stabilized, what is the plan of our treatment? How we plan? First, what would be the prophylaxis to ताकि नेक्स्ट हमारे पास कोई और इस तरह की एपिसोड वीटी की ना हो. We usually use the beta blockers. These are used on the calcium channel blockers, weight limiting ones. Like verapamil or diltiazem. But what are the other options in the cases if the patient has more than one episode of the VT? Then we can go for in other options the implantable defibrillators. These are one of the options. Then we can also go for the catheter ablation. So that's all about the VT. Now a general approach towards arrhythmia. Just few seconds. A patient comes to you with palpitations, with nausea, dyspnea, and you check that this is any arrhythmia. Now you have to check if the patient is stable or unstable. Any arrhythmia, regular or irregular, supraventricular or ventricular. If the patient is unstable, go for the shock. Period. And if the patient is stable, then we look, okay, this is a narrow complex or a wide complex. In the narrow complex, if it is regular, in which there is SVT, or irregular, in which there is atrial fibrillation. There is wide complex when there is ventricular tachycardia. And now, according to the type, then we administer the drugs. So this is how we approach towards the patient with any sort of arrhythmia. Thank you for listening.